Welcome. My name is Eve, and I'm Eve from the Bible, and this is my Talks with Eve podcast. My podcast talks about numerous amounts of things, but for right now, we will be talking about diabetes insipidus. Some people get it mixed up with diabetes mellitus. Mellitus deals with the sugar levels. Insipidus deals with your urine, the concentration of your urine. Okay. Sorry. Without further ado, let's go ahead and start Talks with Eve podcast, diabetes insipidus. What is diabetes insipidus? Insipidus, it means to run through you. Like, okay, in diabetes mellitus, the sugar is running through you. You're not utilizing your sugar, it's just in your blood system, okay? Well, in insipidus, your water is running through you, okay? Sorry, I don't want to get that mixed up with, okay, diabetes, meaning, okay, in disease. Okay, so let's say insipidus. Without bland. So, insipidus means without taste, bland. Back in the day, when diagnosing individuals with diabetes insipidus, the doctors used to drink the urine to distinguish between if the patient had mellitus, that was your sugar, or insipidus. In mellitus, your urine is going to be sweet because you're peeing out your sugar, okay? But in insipidus, you're peeing out your water only, okay? So, what does it happen? Well, we first have to understand the hormone that's at play here, and that's ADH, or your anti-diuretic hormone. All right, it's released it's made in the hypothalamus. The hypothalamus releases anti-diuretic releasing hormone into the pituitary gland, the posterior portion of the pituitary gland, and the pituitary releases the ADH hormone, okay? I'm sorry if I'm getting all over the place, but I think I'm staying in good measures, okay? So ADH is produced in the hypothalamus, but it's stored in the posterior pituitary gland, okay? So when your body needs it, ADH gets directly put into the bloodstream by ways of the posterior gland. Okay, once it's in the bloodstream here, it goes to the kidneys and it hooks on to the receptors of the kidneys, and it makes the kidneys hold your water. It's holding on to it. So we got some water here, but we hold on to this water. What are some factors that will stimulate the release of ADH, your anti-diuretic hormone? Just look at the name. Anti, I mean no. Diuretic is peeing. Okay, so no peeing hormone. You're not going to be peeing. You're going to be holding on to your water. Okay, so triggers that will stimulate the release of ADH is having low blood pressure. Your body is like a machine, okay? It can solve what's wrong with itself, but sometimes it needs outside medications to help it get back to running normal, okay? So with low blood pressure, what is that? You're not able to push that blood through your vessels, right? So ADH is going to help you be able to do that. How? Well, if I don't have a lot of fluids in my vessels for the heart to pump it through, if I'm a hormone that holds on to water, well, all the water is going to be recycled back to the bloodstream, and that's going to help with my blood pressure. You need fluids inside your vessels to have a good blood pressure, okay? What is another trigger that triggers ADH to be released? High serum osmolality. I know that's a weird word, but what that really means is, let's say we have some cereal, okay? The cereal is going to represent the minerals in your blood. Just crush that cereal up, okay? Now put some milk in it, stir it up, and act like that those crumbs of cereal is dissolving in the milk. Just because you can't see it don't mean it's not in there. It's still in there, okay? But what happens if you're peeing out your milk? All that cereal is going to clump up together, and it's going to make it high. It's going to be the concentration of your solutes in your blood. It's going to be high because it ain't swimming. It's just standing still, and that will trigger ADH to hold on to your water and recycle it back into the bloodstream to space that out. Okay? What's another trigger that triggers ADH? We talked about low blood pressure. We said high serum osmolality. What's the next one? Low blood volume. And that's really what we've been talking about. If you don't have enough fluids in your vessels, okay, that hormone is going to put it in there, and it's going to increase the blood pressure, okay? It's going to smooth out that high concentration of your solutes in your blood, okay? So we don't want to get this hormone mixed up with SIADH. SIADH, or syndrome of inappropriate anti-diuretic hormone. I want to make sure I'm saying that S part. SIADH. Syndrome of inappropriate anti-diuretic hormone. And this one, you got too much of that hormone being put on your kidney, so you're absorbing all of your fluids. And this is bad because you can drown from the inside out, okay? We understand we're a machine. We are a machine. There's fluids inside your vessels just as well as there's fluids outside of your vessels. If you can take the top lid off your head, of course the water is going to be woo, okay? But you're full of water. And when you have syndrome of inappropriate anti-diuretic hormone, or SIADH, you're holding on to all the fluids in your tissues that's trying to get drained. You're holding on to it, and you cause them to swell up and drown even more. We'll talk more about that because that's very dangerous for that to happen, okay? But what we're going to talk about now is central diabetes insipidus. And it's called central because something is happening or targeting the brain that's preventing ADH from being released. If you're not releasing ADH, what are you doing? You're going to be peeing out your water. So when your body needs to hold on to it, this hormone is not there to hold on to it. And that's why your urine is going to be diluted, watery, okay? With central, you could have a tumor, not necessarily tumor, that's going to make it increase more. You could have surgery to where the doctor accidentally cuts the hypothalamus. ADH is produced in the hypothalamus, but it's stored in the posterior and pituitary gland. So what happens if you're going to go brain surgery and they cut it? Well, you're not going to be producing this hormone to hold on to your water. You're going to be peeing it out. Let's talk about the pathway, because if the brain is injured and I'm trying to produce ADH, what's the mechanism? What's the pathway that it undergoes? Again, in the hypothalamus, the anti-diuretic releasing hormone is pushed out by the hypothalamus. Oh, wait, sorry. Pathway. ADH is produced in the hypothalamus, and then it's stored in the posterior and it's stored in the posterior pituitary gland. Again, y'all have to say I have done another about 2 more lectures, and so it's me coming back to recall all of this. Okay, so the hypothalamus creates ADH, and it's stored in the posterior pituitary gland. Okay, so if you it just directly releases into the bloodstream. So if you undergo surgery that's cutting that, this is what makes it central. It's what it means. It's because of something in the brain that's causing for you not to hold on to your water. It's central. It's happening. The hypothalamus is in the center of the brain, and if it's messed with, that's why it's known as central diabetes insipidus. So what's a diagnostic tool that doctors use to make sure that it's central? Well, if you're low on vasopressin or ADH, and I give you some more, and things start acting normal, going back to normal. So what I'm saying is, if you didn't know that you got cut in your hypothalamus, but you're peeing like out the wazoo, okay? If they give you vasopressin and your urine starts to become more concentrated, because before it was just you peeing out your water, it was real diluted. And so they give you vasopressin and it starts coming yellow, starts being normal urine. That's how you know that it's central. You need to keep remember that. Okay. So the medications that's given in diabetes or central diabetes insipidus is vasopressin. That's all you need. Okay. It's important to be able to hold on to your water, because if your blood pressure is low and your body can fix it, but you're not giving it what it needs to fix it, you can die. A low blood. What is so important about blood pressure? Every cell in your body needs oxygen, nutrients, glucose, okay? Your circulatory system acts like a river, okay? Just like we got ships that float on the water and bring us our things we need that we order and stuff like that. The cells are ordering stuff and the blood is going to deliver it, okay? You need something that's going to push that blood water through. It needs to be good pressure so things can move up. If it's low, what's moving? You have one heart with all these strings attached to it to supply blood, or blood flows through it, okay? All right, so we talked about central diabetes insipidus with that. There's something happening in the brain. You could have a stroke, a blood clot preventing the flow of blood to the hypothalamus to be able to produce ADH, to be able to retain your fluids. Anything that goes on with the brain that prevents ADH from being produced is central DI. And your urine is going to be watered down. It's going to be water. And how you know you fixed it is if your urine turns back yellow again. Okay, your body gonna hold on. It senses that it's letting go of its fluids. So it's gonna retain that sodium. That sodium is it's like a magnet to water. It's going to draw the water out of your tissues into the bloodstream to up the blood volume. But what's going to happen to that water once it does that? You're going to pee it out. Do you see how you're sucking the life out of your organs with this disorder here? So you'll have diluted urine that's watered down. The concentration of your blood is going to be very concentrated because you just have solutes and not water. And you say urine, and your sodium levels are going to be elevated. And you're going to be peeing like crazy. We talked about, and you're going to be very thirsty. Hey, you're going to be very thirsty here. Okay, the 2 P's in diabetes insipidus is polyuria, because you're going to be constantly peeing, and polydipsia. You're going to be very, very thirsty. Patients here, you can drink up to 12 liters of water a day. That's exhausting. But you're going to be so thirsty because you're not holding on to your water. Okay. Now we're going to talk about, see, this lecture, you ain't had a lecture like this, too. You ain't had a lecture like that, because I'm getting all in there. Okay. This is my podcast. The video that you see here will be downloaded and split into sections for my podcast channel. Okay. So we talked about diabetes insipidus. I want to make sure. We talked about your serum osmolality is going to be increased. Your urine osmolality is going to be decreased. Urine osmolality means your urine concentration. It's going to be decreased because it's just going to be water. Okay? And your sodium levels are going to be elevated. How do you fix this? You give the patient vasopressin. That's going to make their urine go back to normal, and that is key evidence that you fixed the problem. Now, let's talk about nephrogenic diabetes insipidus. You got ADH, it's elevated, but you're still peeing out your water. This is how you can tell if it's central from nephrogenic. If it's central, you just need vasopressin because the organ that produces it is gone, or there's something that But if I get vasopressin and nephrogenic, there's nothing going to happen. Why? Because there's something in the kidney. There's something wrong with the receptors on the kidneys that's rejecting ADH from binding onto it so that it can hold on to the water. So that's why it's called nephrogenic. The nephrons in your kidneys are responsible for allowing ADH to bind to them so that water can be recycled and reabsorbed back into the bloodstream. But if the kidneys reject it, you see how you wouldn't be able to hold on to your water. You're going to be peeing it out. It's important to know which kind of diabetes insipidus that you have for proper treatment. If I give you vasopressin and you're nephrogenic, that's not going to help you none. Okay? So what do they do for patients in nephrogenic? They give loop diuretics. It's going to help you retain your water. Because if nephrons are damaged, sometimes you can't fix it. With nephrogenic, your serum, it's the same thing with central diabetes insipidus. Your urine is going to be watered down. The concentration in your blood is going to be high because you're peeing out the water. You got all those solutes, it's, on top of each other, piling up with no water. And your sodium levels are going to be elevated. So the same lab, with your urine, your blood osmolality, and your sodium, they're going to be the same in both central and nephrogenic. It's just that when you give vasopressin, central is going to go better, but nephrogenic is going to stay the same. So you know not to give vasopressin and nephrogenic because it's not going to help you. You need loop diuretics here. I think I have said what I need to say on this podcast. I just know that in both central and nephrogenic, you're going to be constantly peeing. Your urine is going to be diluted. I mean, it's going to be real watery. Your blood concentration or your serum osmolality is going to be increased because you're peeing out your water, and that is going to increase the sodium levels in your blood. That sodium is going to attract the water from your tissues out so that it'll be in the bloodstream. It's like, I got multiple ways to get that blood volume increased, and your sodium is being used to draw the water out of your tissues into the blood vessels. See, and because you don't have ADH, you're going to be peeing that out. You're literally, your brain, your organs are literally going like this. I'm going to get a good piece of paper. So these are your organs. With sodium drawing the water out, you're slowly but surely shrinking your organs. This can lead to seizures. This can lead to LOC changes, level of consciousness changes, altered mental status, death. This is no game here. When dealing with that water, you need fluids in your vessels. Okay? So now let's talk about syndrome of inappropriate antidiuretic hormone. This is where you got too much of that hormone ADH binding onto the kidneys. You're holding on to that water. All of it. So it's going to be the opposite that when we talked about with central and nephrogenic. Your urine is going to be concentrated because you're just holding on to your water and peeing out your solutes. Your sodium levels are going to be decreased because all that water is spacing out that sodium to the point it's like it's not there. This one usually is called diluted hyponatremia because all that water is spacing it out. And if you don't have sodium able to be the gradient or the electrolyte to help pull water in and out because it's diluted, what do you think is going to happen to your tissues? Look, they're going to swell. Your brain is going to swell to the point of death. When he said he made this strategic, he did. So what do they do with patients here? Of course, fluid restrictions. Why would you give them water if they're retaining it? Salt tablets. They need to have their sodium levels increased because that can lead to death too. You loop diuretics. Get that fluid off of them. Okay. SIADH can be chronic or acute. I want to go back to nephrogenic DI and talk about the purpose of treatment. They're going to induce mild hypovolemia. I asked myself, they're like, why would they do that? Well, here, they're going to give a little bit of fluids because you're draining out your fluid. I asked the same thing. Like, why would they induce mild hypovolemia? Well, they're going to put a little fluid inside of you so that it'll help you a bit. It's your kidneys acting up, not retaining the fluid. With central, all they got to do is replace your vasopressin. But with nephrogenic, it's, you're losing your fluid. So they're going to put a little bit of fluid in you and have you a sodium restriction. Sodium restriction because your sodium levels are high. Too much sodium can kill you too. And I think we have conquered central diabetes insipidus, nephrogenic diabetes insipidus. We talked about syndrome, inappropriate antidiuretic hormone. Now it's time to get on the next subject,